temperature, body temperature, correct? It's got an abundant air supply because we're constantly inhaling and exhaling oxygen for it. It's also, because its blood supply got a very good nutrient supply, it is the optimal place for them to set up home, isn't it? And of course, if they set up home down here, we have pneumonia, correct? And so, how do we take care of that? Do we have any defense left? And the answer is yes, but we have to do it a little bit differently here. What we've got are what we call dust cells. You can see they've got them labeled, maybe not the best image quality here, but it showed a lot of dust cells, is why I chose to use this one. I mean, you can see that they've got a couple labels there. Here's a couple more. Here's one here, here's one here. You can see they're in the lumen. Sometimes they'll be sitting right up against the wall of alveolus. And this one I can still make out it's separate, can't I? I can see a little bit of a line there. Sometimes you'll see it labeled there and you say, whoops, I thought that was an alveolar type 1. Like there's an alveolar type 2. There's an alveolar type 2 right there. It's a part of the wall. Whereas here is a dust cell. You can see it's not really part of the wall. Okay, it's just up against it. Okay, I'll typically give you one where you can see it well like this, or you can better yet, something like that. Okay, what are these dust cells? Well, these dust cells are blood monocytes that have squeezed out through the capillary wall, because they normally prefer post-capillary vanules, correct? But they'll come out through the capillary walls, out into the lumen, and they will then phagocytize pathogen or any debris, hence their name, dust cells. Okay? What do you do afterwards? Well, you know that macrophages move by amoeboid movement. They will crawl up that branching network until they finally get to where the cilia are. Once they get where the cilia are, the cilia can sweep them along. Sometimes it's referred to the fact that they go up that mucociliary escalator. Okay, but you know they'll have to move by amoeboid movement until they get where cilia can help move them along to get up to the up to your throat region so you can swallow them. Now these can be very abundant if you've got an infection. The way they got this on a mouse is they just raise that mouse in a dusty environment. You know, if you work in a coal mine, there's a lot of dust, or you work in a grain mill where there's a lot of dust, you're going to have a lot more dust cells. Okay? Just think about it. If you breathe in more dust, that dust contains pathogens, you're going to find a lot more monocytes coming out of circulation to take care of that dust within the lungs. All right? And so that's the dust cells, that's what they do. The last thing, or second to last thing to talk about here with the alveoli, are what we call alveolar pores. We used this image earlier. It had a pore on it. The textbook did not label it. Whereas, you know, this alveoli has a huge opening, let's say, you know, the size of my hand here in front of the screen. Between adjacent alveoli, you can often have little tiny openings called alveolar pores. And those alveolar pores are just an alternate way to get air into that alveolus. It turns out as you get older, you get scar tissue blocking off alveolar ducts and the like. You lose alveoli, that's why I don't have the lung power I had when I was your age. Okay? I'm not going to have the lung power if I was an endurance type athlete anymore because I'm losing alveoli. Well, if you lose alveoli, if the alveolar duct connecting to that large alveolus right there is now blocked, it's got scar tissue so I don't get air in and out, I can still get at least some air in that alveolus from an adjacent alveolus supplied by a different alveolar duct, which is still intact. Does that make sense? It's just a way to get some use out of alveoli who are blocked upstream, that we can still get at least some air in and out through an alternate pathway, a tiny trap door, so to speak, that we can get air in and out there in order to be able to still use this alveolus right here. All right, the last thing to talk about here is, you know, there's that, we talked about the capillaries within the walls, and that's really providing the thickness of the walls as the capillaries there. There's also, you know, just tiny amounts of connective tissue we really can't see, but if we stain it with just an elastic stain, which is what we've done right here, Van Giesen's elastic stain, you can see that, you know, individual pockets there are alveoli, but the black in there will be elastic fibers. Even within the walls of the alveoli, there are elastic fibers, but this coincides with what you talked about in anatomy and physiology. how that you use muscle activity, normal respiration, like you're using right now. You're gonna use muscle activity to inflate the lungs. What are you gonna do to deflate the lungs? Just relax the muscle, and the elastic nature of them forces the air out for normal expiration, correct? Here's some of those elastic fibers. You can see them right here. I love histology because it makes sense to everything else you talk about, doesn't it? All right. The last thing we're going to talk about here before we go into lab is the lining of the pleural cavities and the outer lining of the lungs. We refer to that as the pleura here. And what we see on this image right here, if you look, the visceral pleura, which is on the outside of the lungs, it's in red. And if we follow it right here, it comes up, and where it hits that primary bronchus, it's now going to turn and reflect back out and become the parietal pleura that lines the thoracic cavity. Okay? And so they are continuous there. They're just given different names, whether they're on the lung or whether they're on the thoracic cavity, but they're continuous because it reflects back up right there, takes a U-turn, and switches from being pink to blue, okay, red to blue, right there, and so they're continuous there. Visceral pleura, visceral means organ, so that's what's on the lung itself, and the parietal pleura is what's on the chest cavity. If we look at it histologically, first of all, it's just a lining. It doesn't have any great purpose to it. What do we expect? Simple squamous, correct? It's energetically the easiest one. You don't have to maintain as much cytoplasm, so it's the cheapest one to maintain. And that's what we're looking at right here. If you look up along the surface there, you can see the pancake nuclei. We're labeled with an M as one right there. Pancake, long axis, parallel to the surface, only one cell layer thick, making it simple squamous. Now we give it a special name here. We call it a mesothelium. We call it an endothelium when it lines the blood vessel. Here, when it's lining the outside of the lungs or lining the thoracic cavity, we'll refer to it as a mesothelium. Now this mesothelium, beyond just providing a covering here, it secretes a small amount of serous fluid. And that small amount of serous fluid makes it so that when you inhale and exhale, as the lining of the lung is sliding against the lining of the thoracic cavity, it slides very easily. Best analogy I've got there, when you made a wet mount on a microscope, put a drop of pond water in it or a drop of water, and then drop that cover slide on there, that cover slide really slides easily, doesn't it? That's what's happening here between the two linings. When you do this, you open up for surgery, you look at the linings there, they're glistening, they're moist, they have a glassy-like appearance. That's because there's just a small amount of serous fluid there, but all you need is a tiny amount of moisture in there, and they slide much more easily. Now, because it is only one pancake cell layer thick, it can be damaged by surgical procedures, by infections, things like that. And connective tissue down below is sticky, so if you have connective tissue from the lung, connective tissue from the thoracic cavity, if they're sticky, they can form an adhesion, and that might have to be taken care of surgically then, because now the lung can't slide against that thoracic wall anymore like we've been talking about. All right, questions at all there? Now, oops, I don't have the image to show up, but there's also plenty of elastic fibers in here as well.
Can you show elastic fibers on the 21?
Okay, the elastic fibers are what are staining black, dark. Okay, the Van Giesen's elastic stains elastic fibers black or very dark brown in some recipes. But basically, those are the walls of alveoli, and you can see elastic fibers in there. All right. All right, let's move on and go through some lab slides here then. Yes? Yes, yeah. Enteroendocrine, the older term, neuroendocrine is the newer term coming in. Basically, they're first discovered in the digestive system. You see they're major players there in terms of what they do. We'll see that when we get there. And they were named enteroendocrine there, and then they started calling them enteroendocrine when they found them in the respiratory system as well. People saying, wait a minute, entero means GI tract. We'll start calling them neuroendocrine. So I tend to use those terms interchangeably without thinking about it.